Welcome to Who's Who on Fox 5 Plus. I'm Sonny Segal in Washington, D.C. Our guest today has dedicated his career to helping control global infectious disease pandemics like the one we are currently experiencing with COVID-19. His work includes pandemics such as influenza, coronaviruses, Zika, Ebola, and others. Dr. Rashid Chotani is a well-known expert in biosecurity, health surveillance, medical countermeasure development and healthcare management, and the diagnosis of human and zoonotic diseases. He is currently working on the novel coronavirus, which has caught the world unprepared and claimed almost 300,000 lives in just a matter of months. Dr. Chotani, you were awarded NATO's Scientific Award for Counterterrorism in 2016. Your groundbreaking research and development of advanced programs for man-made, naturally occurring, or genetically modified biological and chemical agents is directly relevant to the novel coronavirus. Your experience in guiding governments and the private sector the past 20 years is commendable. Is the novel coronavirus unlike other viruses and situations? World leaders certainly seem to be challenged in balancing public safety with the economy. Countries and states are slowly lifting restrictions before a cure or prophylaxis has been found. How could that affect the number of cases and deaths due to COVID-19?
Good morning, Sonny. Thanks for inviting me to your show and the kind introduction. I've been working on the novel coronavirus since January 2020. Currently, it has caused close to 5.8 million cases and 360,000 deaths worldwide. That's a huge number. US has been really hit hard with over 1.7 million cases, and now our total deaths have exceeded 100,000, which is a tragedy. The disease is currently exploding in Brazil, Russia, and India. With no vaccine or drug, the world is facing a serious problem. We have seen two other coronaviruses, one in 2003 called the SARS coronavirus, and the other one in 2012, which was called the MERS coronavirus. Both of these viruses spread across the world, but SARS, which spread to 26 countries, resulting in 8,000 cases and around 775 deaths, disappeared completely, never to appear again. The MERS coronavirus, however, has stayed with us. The virus since 2012 has caused an outbreak every single year, large numbers or small numbers, in the Middle East. And the biggest outbreak was seen in 2014. Now we have this new virus that we first called the SARS coronavirus 2 or SARS-2 coronavirus or novel coronavirus 2 that causes the disease COVID-19. The world has never seen this virus, and the global population has no immunity against it. So we never saw this virus. We were not really immune to it. Thus, what we call is this was a virgin population. And the virus saw that and spread widely and across the world. So yes, it is different. And a virus which has not only baffled world leaders and legislators, but clinicians and scientists. We are still learning about the virus, and every day something new is discovered. I understand the dilemma of the world leaders and how to balance public safety with economy. We do not have a vaccine, prophylaxis, or a cure drug, and countries and states are lifting restrictions. Their argument is how long can we not open the economy? Unfortunately, I have to agree, but with some caution. Another critical point to appreciate in the developing world is the existing poverty. And the concept of eat and feed your family what you earn today. The economists are arguing that hunger will kill more compared to the disease itself. So where does the balance rest? We have already seen a number of cases increase in some states and countries where restrictions were lifted. These numbers and deaths will continue to rise as we do not have a medical countermeasure vis-a-vis prophylaxis or a cure, and neither are we anywhere close to having what we call herd immunity. Let's talk a little bit about that. When most of the population is immune to an infection, this provides indirect protection, that is herd immunity. We also call it herd protection to those who are not immune to the disease. For example, if 80% of the population is immune to a virus, just take it for an example, 80% of the population is immune to a virus, 4 out of every 5 people who encounter someone with the disease won't get sick and won't spread the disease any further. So you kind of block the spread of the disease that way. In this way, the spread of infectious diseases is kept really under control. Depending how contagious an infection is, usually 70% or 90% of the population needs immunity to achieve what we call herd immunity. We don't have that. And we really don't want this virus to spread widely and cause tremendous amount of disease in the entire population because there is a mortality rate associated with it. So we don't want to lose lives. So in the absence of a vaccine or a therapeutic or a cure or a prophylaxis, what we need to do is to remain diligent about practices like social distancing and hand washing, expand testing and develop accurate, efficient, and cost-effective testing ways using point-of-care diagnostics for PCRs, antibody, antigen. These are the key ingredients of being prepared. We are still not there. We need to enhance our tracking system by enhancing traditional and non-traditional surveillance methodologies such as sentinel surveillance, syndromic surveillance, wastewater surveillance, which is a new field that is being looked at. We need to scale up contact tracing, make provisions that there are no shortages of personal protective equipment, ventilators, medications, medical supplies, testing kits, and reagents. And we need to continue on developing the multiple therapeutics and vaccines that we are working on. So there's so much work that needs to be done and so many things that need to be achieved, and we have very little time to do that, and thus we all have to work together in order to get to that point.
In lifting restrictions and lockdowns, who should really be making the decisions?
The decision will be made by the legislators and the people who are in charge of running the countries. However, if decisions are made in a void without the advice of public health and academia, and without taking science and data into consideration, the outcomes will not be favorable. Yes, the economy has to restart. People are tired of being locked up, but if we lose sight of the data, and that is the most critical thing, and not have safety valves for phase in and phase out processes. The legislators and the world leaders, if they don't consider lives before political survivalship, things might get really ugly, especially as we move into the second wave of this disease. And most of the experts agree that we will have a second wave coming this September-October timeframe. So we've got to be ready and be prepared.
As Chief Scientific Officer and Vice President of Medical Affairs at WVS, can you say if future doctors and doctors in training will change their choice of specializations because of COVID-19?
Yes, this pandemic has affected medical students adversely. Medical students are not considered essential workers. And during the pandemic, when the outbreaks and epidemics started, they were sent home. And they were now doing online courses. During the last 2 years of the training, the medical students get hands-on practical experience and education in a hospital setting. This education cannot be conducted online. So I believe that, yes, there is a problem in terms of how much training that they were supposed to get, hands-on training, and how much training did they get. I'm extremely concerned about the time lost and additional time that could be lost as medical students might be sent home if there was a major outbreak at a hospital or a community, and they were not getting the appropriate training that is needed for them to graduate.
As adjunct professor at the College of Professional Studies at the George Washington University in Washington, D.C. on public health and crisis communications, is it possible that critical infrastructure such as sewage or drinking water may become transport mechanisms for COVID-19?
The virus that causes COVID-19 has not been detected in drinking water. Conventional water treatment methods that use filtration and disinfection, such as those in most municipal drinking water systems, should remove or inactivate the virus that causes COVID-19. COVID-19 has been found in feces of some patients diagnosed with the disease. However, it is unclear whether virus found in feces may be capable of causing the disease itself. There has not been any confirmed reports of the virus spreading from feces to a person. However, we know that the virus is shedded via feces. Scientists also do not know how much risk there is that the virus could be spread from feces to an infected person, often infected person rather, to another person. So we don't know a lot about it as yet, but we, again, as I said, know that the virus is shedded in stools or feces. However, according to CDC, the risk is low based on data from previous outbreaks of disease caused by related coronaviruses such as SARS and MERS. It is not yet known whether the virus can be transmitted what we call the oral fecal route or the fecal oral route. However, we know that the viral shedding from digestive system can last longer than shedding from respiratory tract. So in essence, the shedding starts early and it stays much longer compared to the viral shedding from the respiratory tract or sneezing or coughing. Therefore, this could be an important but yet unqualified path of increasing exposure. A lack of testing that we have experienced and we still have, we're getting better in that, makes it difficult to predict the scale of potential spread and the public health implications of the virus. Arriving at waterways treatment works. That is, the implications of consequent discharge into the wider environment are not just beginning to be looked at or being investigated right now. We need to do that. There are some studies that are going on that are looking at some of that. Structural makeup of COVID-19, specifically its lipid envelope covering, suggests that it will behave differently in aqueous environments compared to those viruses typically found in the intestine. There is currently limited information on the environmental persistence of COVID-19, but other coronaviruses can remain viable in sewage for up to 14 days, depending on the environmental conditions. On the risk of human exposure in the transport of coronavirus in water could increase the potential for the virus to become aerosolized. Now, you can imagine that this wastewater, when it gushes through one point to the other, there is some aerosolization, particularly during the pumping of wastewater through sewage systems at the wastewater treatment works and during its discharge and subsequent transport through the catchment drainage network. So there are multiple ways that can happen. Now, there is a couple studies, one being done at Yale. I believe the paper was already published a couple days ago, and another one that was being done at Stanford. For the past 3 weeks, so actually more than that, about a month, myself and some of my colleagues have been thinking about what if we can detect the virus in wastewater or the sewage system. And wouldn't it be great if we then would be able to tell communities that there might be more virus at certain times compared to other times? Because as we all know, the the viral shedding starts way before you develop symptoms. So at least a week before that. So if we were able to see the intensity of the virus in the sewage system of a given geographic area, we would be able to say early. It could be an early warning system, essentially. That's what I'm talking about. We could say that, listen, in this particular area, we are seeing more virus in the wastewater system compared to other areas. So intervention should be implemented in this area. So that's another science that's being developed right now. And I'm extremely hopeful that there might be a way to do some early warnings if this science particularly works for coronavirus through wastewater systems.
Could medical education change altogether influenced by COVID-19?
There's a chance that residents, when applying for surgical specialties, anesthesia, pulmonary, or other specialties, where one has to be exposed to the respiratory tract, has to do things such as intubation, they might be extremely concerned and might decline to consider these specialties because of the high risk in those areas. I hope this is not the case. But after talking to some young physicians who've just finished their residencies, I'm a little concerned that some people are extremely worried about it. Their families are worried about it. And are saying, well, this specialty has less exposure or chance of you getting the disease, so why don't you pick this specialty rather than the one where you have a much higher chance? So we still have to consider, but I hope that's not the case, because we come into the profession, there is a risk involved when we become physicians, and I hope that we are brave enough, like the frontline workers that we are, to be able to deal with any kind of circumstance, but using proper measures, being smart about it, not forgetting that we've got to take into consideration data. We have to have personal protective equipment. We've got a mask. We've got to do all the things that are needed to protect ourselves, and then on top of that, be extremely careful.
I want to share with the audience that you are highly published and that a impressive list of books and publications, blogs and others are on your website at drchotani.com. Dr. Chotani, thank you for being on Who's Who today. You have provided us with valuable insight. I want to thank you for all your work on behalf of humanity, sir. Thank you very much. This is Sonny Segal on Who's Who. I hope you'll join me soon for another segment of Who's Who, when I'll have another very informative guest.